Hi everyone, I welcome you all to the IP Corner, and in this video we'll be talking about post-intubation tracheal stenosis. I'll be talking about a patient who came to us 1 month ago and we did some intervention. So let's proceed and see what happened. So this is the first case of this IP Corner. This patient was 18-year-old male student by occupation and came to us with the chief complaints of shortness of breath, which progressed from grade 2 to grade 3 MMRC since last 1 month. There was also the signs of stridor, and which was present since last 15 days. There was no history of any autoimmune symptoms, no history of tuberculosis, no history of any other diseases in the family, and there was no significant exposure history in this patient as well. On examination, the saturation of the patient was 96%, but there was no significant finding in the general or systemic examination except for the stridor, which was present. If we talk about the patient's past history, there is a very significant history. That patient was admitted in local hospital and was put on invasive mechanical ventilator on 1st November 2024 to 5th November 2024. So this is a very significant history. And for the stridor, the patient was tried for balloon dilatation 3 times in the previous hospital where he was admitted a few days ago. So this procedure was done a month ago in our center. So let's proceed further. The lab investigations are normal, nothing is very significant. So now we'll move forward. So this is a very important slide in which I want to show about the PFT of the patient. Here you can see that the loop of the PFT itself shows a box pattern which tells us about the fixed airway obstruction in this patient. Let's remember the FEV1 values also. It was 43% and it was 1.36 liter. Before any intervention, when the patient came to us, we directly did the PFT and these were the values. Now let's see what we did the intervention part. Let's play the video. This video you can see clearly there is a stenosis and the bronchoscope could not be negotiated further due to the stenosis, and because of that the patient is having the chief complaints of the wheezing and the stridor. Now we are using the rigid bronchoscope in the twist and turn method. This is called as the coring. So we are removing the stenosis part by doing the coring through the rigid bronchoscope. Now you can see the carina is clearly visible, and we have removed the stenosis part due to the rigid bronchoscope itself. Other things which could have been done is balloon dilatation, but it doesn't work. Cautery and knife could have been used, but the stenosis again comes back. End-to-end anastomosis could have been done, but the patient refused for the surgery, and through the rigid bronchoscope, this was the best possible thing which the patient could have received. So here you can see clearly we have now put a stent on the stenosis part, and we're using the 6 millimeter bronchoscope, and the bronchoscope can easily be seen going through the stent, and we can see the carina, and the patient is better. We'll be showing the PFT afterwards, and this is the procedure which is very simple to do. So this was the PFT which we did after the procedure, just after the procedure next day. Here you can see the loop has now changed. It has become significantly different from what it was before. See the FEV1 values, it's now 2.07 liters and 65%. It was around 43% if I remember. So this is the very significant difference which we can see, and there was a lot of change in the symptoms of the patient as well. He felt a lot of relief and the stridor was caught. So moving forward, there are some learning points which we have to learn from this case and this video or this intervention about the post-intubation tracheal stenosis. So what are the etiology of this kind of situations? It's prolonged intubation, high cough pressure while the patient is intubated, multiple intubations, and systemic conditions like diabetes or GERD can precipitate such condition and contribute to ischemic injury and fibrosis. Now, the presentation with the patient will comes to you. Of course, dyspnea is one of the biggest presentation which was present in this patient, and biphasic stridor which was there, wheezing. So sometimes the patient comes with wheezing and we suspect that it's asthma or COPD. So all the wheezes are not asthma, COPD. This is a perfect example to tell you about this, and symptom may appear just days after the intubation or post extubation, you can say. Taking the extubation or intubation history about the invasive mechanical ventilators becomes a very key factor in identifying or suspecting the patient is having post-intubation tracheal stenosis or not. Now, how do we diagnose it? For the diagnosis, bronchoscopy is of course the gold standard, because you can see clearly with the help of the camera. You can use the direct, the rigid bronchoscope or the flexible one. So I prefer doing with the rigid one because you get a lot of freehand by putting different instrument, biopsy forceps or balloon, whatever you can do. So rigid is advisable directly. Now you can also diagnose with the help of CT scan with 3D reconstruction for the assessment of the severity of the space present in the due to the intubation tracheal stenosis, and PFTs, which is very important to know that how much change in the volume the patient is having. And of course you get the loop, the classical loop, box shaped loop, to understand that patient is having a fixed airway obstruction. Now, how do we manage it? There are different ways of management of post-intubation tracheal stenosis. Now, in mild cases, you can use balloon dilatation or laser resection, but laser is pretty much costly, not available everywhere. So, balloon dilatation you can do, but sometimes balloon dilatation doesn't work because a lot of fibrosis comes around. And even if you try doing a lot of times the balloon dilatation, that doesn't work and the stenosis comes back again. In this patient also, it was tried 3 times, but it failed. So what are the other options left? So in severe cases, you can do rigid bronchoscopy guided coring, which we did, and then later on put a stent, or the silicon stent you can put for the airway restoration and the prevention of the stenosis to come back again. So this is a very good scenario where you can use a rigid bronchoscope guided coring and create a space and put the stent. Now, what is the definitive treatment? If somebody asks you, is the only thing which we can do? No. The definitive treatment is of course surgical resection and anastomosis for the the segment which is stenosed. They directly cut both the the trachea and put it together with the help of, and the suture it with the help of anastomosis is done, and you get the proper results. But in this patient, we couldn't do the surgery part because they refused to go for surgery, maybe because of the age or maybe because of the cash issues that they have, whatever it is. But not everybody will be agreeing on this for the surgery part. So if they don't agree, then you would definitely go for the rigid bronchoscopy guided coring and then putting a stent over it. So how do we prevent it? Maintain a cough pressure of less than 25 centimeter of water, then minimize intubation duration. We try to extubate the patient as quickly as we can, and we use small sized endotracheal tubes, and of course ensure proper tracheostomy care. So I hope you understand this video, and if there is any doubt, you can reach out to us through our website, and I'll be happy to share a lot of different cases with you all. Thank you. Keep watching.